Have you ever stopped to really think about how you breathe? I mean, how do we actually move air in and out? What's the physics behind it that makes it seem so effortless, usually?
It does seem simple, doesn't it?
Yeah. So today we're taking a deep dive into pulmonary mechanics. We're drawing specifically from Chapter 27 of the latest Boron and Boulpaep Medical Physiology.
Exactly. And our goal here is to really unpack this. It can be dense stuff, but it's so important. We want to make it clear, engaging, but still, academically accurate.
Sort of build it from the ground up.
Right. Connected to clinical scenarios, help you really grasp the why. Think of it as maybe a shortcut to understanding the core ideas without getting totally lost.
Okay, let's start with a fundamental balance. Inside your chest, you've got your lungs. Imagine they have this natural springiness, wanting to recoil inward, like a deflated balloon. That's their elastic recoil.
But then pulling the other way, you have your chest wall. Yeah. It also has elastic recoil, but it wants to spring outwards.
So these two opposing forces pulling in opposite directions.
Exactly. They don't touch directly, though. They interact across this tiny fluid-filled gap, the intrapleural space.
Okay.
And because the lungs pull in and the chest wall pulls out, this space becomes essentially a vacuum relative to the outside air. This creates what we call intrapleural pressure, or PIP.
And that pressure is always negative, right? Lower than the air pressure around us.
Always negative at rest, yes. It's the pressure inside your chest cavity, but outside the lungs or blood vessels themselves.
Now, here's something really interesting I found, that PIP, it isn't actually the same everywhere in the chest, is it?
No, it's not. When you're standing upright, gravity plays a role. It pulls down slightly on the lungs.
So near the top, the apex, the pull is stronger.
Kind of, yeah. It creates a slightly greater vacuum, so the PIP is more negative, maybe around negative 10 centimeters of water. Down at the bottom, the base it's less negative, closer to maybe negative 2.5.
Wow. So the air sacs at the top are actually a bit more stretched open at rest?
They are, slightly. And we often just use an average PIP, maybe negative 5 centimeters of water after a quiet breath out, just for simplicity.
But that average balance is critical.
Absolutely crucial. Think about what happens if it's disrupted. Say, in pulmonary fibrosis. The lungs get stiff, right? Their inward elastic recoil increases.
So they pull inwards harder.
Exactly. And that usual magnified PIP isn't enough anymore to keep them expanded to their normal resting size. The resting lung volume actually decreases.
Which makes breathing feel difficult, stiff.
Precisely. It directly impacts how much air you can hold.
Okay, so we have this resting balance. How do we actively change it to take a breath in? Inspiration, that's active, right?
Always active. It needs muscle power.
Yeah.
The most important muscle here is the diaphragm.
The big dome-shaped one at the base of the chest?
That's the one. When your phrenic nerves tell it to contract, it flattens out, moves downwards maybe a centimeter or so in quiet breathing.
Increasing the top to bottom space in the chest.
Yep. And then you have the intercostal muscles between your ribs. Certain ones, the external and peristernal internals, they contract too.
What do?
They stiffen the rib cage and lift the ribs up and outwards. Think of it like a bucket handle. Lifting increases the side-to-side diameter.
Oh, okay.
And the upper ribs also move the sternum, the breastbone, up and forward, like a pump handle. That increases the front-to-back diameter.
So diaphragm down, ribs up and out, the whole chest cavity gets bigger.
Significantly bigger.
Yeah.
And when that happens, the intrapleural space expands, making the PIP even more negative, a stronger vacuum.
And the lungs just follow.
Passively, yes. They get pulled open by that increased vacuum filling the larger space, and that pulls air in from the outside. That's inspiration.
And for a really deep breath, a forced inspiration.
Then you recruit backup muscles, accessory muscles like the scalenes in your neck, the sternocleidomastoids. They pull the ribcage up even further.
Got it. So what about breathing out?
Exhaling.
Well, the cool thing about a quiet exhalation is that it's usually passive.
Passive. Remember that elastic recoil of the lungs. They store energy like a stretched rubber band when you inhale. To breathe out quietly, you just relax.
Relax the diaphragm and intercostals.
Exactly. They relax, the chest cavity volume decreases. The stored elastic energy in the lungs makes them recoil inwards, and air flows out. No extra muscle work needed.
But it's not always passive.
Not always. If you do a forced expiration, like blowing hard, or even if you're breathing quietly but have a condition like asthma that increases airway resistance.
Then you need extra help.
Yes. Then accessory muscles kick in. Your abdominal muscles contract strongly, pushing the diaphragm upwards, really squeezing the chest cavity.
And some other intercostals pull the ribs down and in.
Right. All that makes the intrapleural pressure less negative, maybe even slightly positive, pushing the air out forcefully.
Okay, let's switch gears slightly and talk about lung stiffness, or rather, the opposite distensibility. The term is compliance, right?
Correct. Lung compliance. How easy is it to stretch the lungs?
To understand this, maybe think about a worst-case scenario. A puncture wound to the chest. Air rushes into that intrapleural space. A pneumothorax.
Right. The vacuum is lost. PIP goes towards zero, or atmospheric pressure.
And without that negative pressure holding them open?
The lungs' natural elastic recoil takes over and they collapse.
Okay.
The alveoli, the tiny air sacs, just deflate. That's atelectasis.
Okay, so how do we measure how stretchy the lungs are or reinflate them?
We need to think about the pressure difference across the lung wall itself. This is the transpulmonary pressure, PTP. It's the pressure inside the alveoli minus the intrapleural pressure outside the alveoli.
Alveolar pressure minus PIP.
Exactly. And under static conditions, no airflow, the alveolar pressure is basically zero relative to the atmosphere. So PTP just equals the negative of PIP. PTP equals net PIP.
So that transpulmonary pressure is really what's keeping the alveoli inflated against the recoil.
Precisely. And it tells us how to reinflate a collapsed lung. We need to increase that PTP.
Which you could do by making the PIP more negative again, like sucking the air out of the pleural space with a chest tube.
Yes, that's the physiological way in how a chest tube works.
Yep.
Or you could increase the pressure inside the alveoli.
Like with a ventilator in the ICU.
Yeah.
Positive pressure ventilation.
Exactly. Both methods increase the pressure difference across the lung wall, increase PTP, and reinflate the lung.
Okay, so if we plot lung volume against this transpulmonary pressure, what does that tell us about compliance?
Well, if you start with a collapsed lung and inflate it, the curve isn't a simple straight line. First, it takes quite a bit of pressure to pop open the really collapsed airways. Then it gets easier, more linear expansion until you reach the limit.
And I remember reading that the inflation path and the deflation path aren't the same. There's a loop.
That's right. That's called hysteresis. It means basically it takes more pressure to open an airway than to just keep it open once it's inflated. Part of that is due to surface tension, which we'll get to.
And the slope of that curve, the change in volume for a given change in pressure, that's the static compliance.
Yes. High compliance means floppy, easy to inflate. Low compliance means stiff, hard to inflate.
And the opposite of compliance is elastance, the tendency to snap back.
Correct. High elastance means high recoil, like in a stiff lung.
So how does this tie into diseases? Let's take pulmonary fibrosis again.
Fibrosis means scarring, deposition of fibrous tissue, makes the lungs very stiff. So compliance is way down.
Harder to inflate. Requires more work, more pressure change for the same amount of air.
Exactly. Patients often compensate with rapid, shallow breaths because big breaths are just too much work.
And the opposite extreme, emphysema.
Emphysema involves destruction of the lung tissue, the alveolar walls. This actually makes the lungs more compliant, floppier.
Easier to inflate initially.
Initially, yes, less effort to get air in. But, and this is a huge but, that destruction also destroys the support structure for the small airways,
So they collapse easily.
especially during exhalation, which dramatically increases airway resistance. So, while inflation is easy, getting air out becomes incredibly difficult.
Both fibrosis and emphysema impact breathing profoundly, just in different ways. Fibrosis is a classic restrictive lung disease, right? Lower lung volumes, difficult inflation.
Yes, along with things like infant respiratory distress syndrome, pulmonary edema, even problems with the chest wall itself, or neuromuscular diseases affecting breathing muscles, anything that restricts lung expansion.
Now, you mentioned surface tension earlier. That plays a huge role in lung recoil, doesn't it? Maybe even more than the tissue itself.
Absolutely. It's fascinating. Most of the inward elastic recoil of the lungs isn't from the elastic fibers in the tissue, but from surface tension at the air-liquid interface inside the alveoli.
Explain that. There's a thin layer of fluid lining the alveoli.
Yes, and where air meets water, you get surface tension. Water molecules are strongly attracted to each other, more than they are to the air. At the surface, this creates a net inward pull, trying to minimize the surface area.
Like water trying to form a sphere or a soap bubble trying to shrink.
Exactly the same principle. This force constantly tries to collapse the alveoli.
And this relates to Laplace's law.
It does. Laplace's law tells us that the pressure needed to keep a bubble inflated is higher for smaller bubbles. P equals 2tr, pressure equals twice the tension over the radius.
So without anything else, smaller alveoli would need more pressure to stay open and would tend to empty into larger ones.
That would be the tendency, yes, which would be inefficient, reducing surface area for gas exchange.
But our lungs have a solution.
A brilliant solution.
Hmm.
Pulmonary surfactant.
Made by specific cells in the alveoli, the type 2 cells.
That's right. It's a complex mix, mostly lipids, especially one called DPPC, dipalmitoyl phosphatidylcholine, plus some special proteins.
And it acts like a detergent.
Essentially, yes, it gets right into that air-water interface. Its molecules have parts that like water, hydrophilic, and parts that hate water, hydrophobic. They orient themselves to disrupt the strong attraction between water molecules at the surface.
Reducing the surface tension.
Dramatically, from about 70 dynes per centimeter for pure water down to 25 or even less.
Okay, so what are the big consequences of having surfactant?
Huge consequences. First, it increases lung compliance. By reducing that inward pull of surface tension, it makes the lungs much, much easier to inflate. Saves an enormous amount of breathing effort.
This is why premature babies lacking surfactant have such stiff lungs, infant respiratory distress syndrome.
Precisely. Second, surfactant helps keep the alveoli dry. It reduces the tendency for fluid to be pulled from the tissue into the alveolar space by surface tension.
Keeps the gas exchange surface thin.
Right. And third, and this is really clever, it helps stabilize alveolar size.
How does it do that?
It's dynamic. As an alveolus expands during inspiration, the surfactant molecules spread out, becoming less concentrated on the surface. This increases the surface tension slightly.
So it puts the brakes on faster expanding alveoli?
Kind of. It helps ensure ventilation is more uniform, preventing small alveoli from collapsing into larger ones and stopping large ones from overexpanding too quickly.
Amazing stuff. Okay, so we've covered the static properties, compliance, recoil, surface tension. What about when air is actually moving? The dynamic property.
Right. Now we have to think about overcoming resistance to airflow. It takes pressure not just to stretch the lung, overcome elastic forces, but also to push air through the airways, overcome resistive forces.
And airflow, like electrical current, follows a sort of Ohm's law, right? Flow equals pressure difference divided by resistance.
Exactly. Airflow is proportional to the driving pressure. That's the difference between alveolar pressure and atmospheric pressure, and inversely proportional to the total airway resistance, RAAS.
And resistance is incredibly sensitive to the radius of the airways. Quasi's law.
Yes. Resistance is inversely proportional to the radius to the fourth power. R is proportional to 1 over R to the fourth.
Wow. So if you have the radius, the resistance goes up 16 times.
It's a huge effect. Even a tiny bit of narrowing, say from mucus or bronchospasm, can massively increase the work of breathing.
How do we even measure this resistance?
Clinically, often using a body plethysmograph. It's a clever device, like a sealed phone booth, that uses Boyle's law to figure out alveolar pressure changes while you breathe, allowing calculation of resistance.
And the type of flow matters too, doesn't it? Smooth laminar flow versus chaotic, turbulent flow.
It does. Ideal smooth laminar flow is most efficient, lowest resistance for a given flow rate. Turbulent flow is chaotic, requires much more pressure. In the lungs, because the airways branch and island aren't perfectly smooth.
It's mostly not purely laminar.
Mostly it's transitional, somewhere between laminar and turbulent. Only maybe in the trachea, during really forceful breathing, might you get true turbulence.
So where is most of this airway resistance located in healthy lungs? You'd think the tiniest airways.
You would think. But counterintuitively, the greatest resistance is actually in the medium to large-sized airways, and even the upper airways like the pharynx and larynx.
Not the tiny bronchioles way down at the bottom.
Not in healthy lungs. Because while each tiny bronchiole has high individual resistance, there are millions of them in parallel.
Ah, like resistors in parallel in electronics. The total resistance drops.
Exactly. The huge total cross-sectional area down there means the aggregate resistance of the small airways is actually very low.
But that changes dramatically in disease, like COPD.
Dramatically. In COPD, especially the chronic bronchitis or small airway disease component, almost all the increase in airway resistance comes from those peripheral small airways. The resistance can go up massively, maybe 10 or 12-fold.
And in asthma.
Asthma is more about inflammation and bronchospasm, often affecting airways of various sizes, but significantly increasing total RAAS. Either way, the increased resistance means much more work to breathe, limiting activity.
Are there things that normally change airway resistance besides disease?
Oh yes, your autonomic nervous system is a key player. Parasympathetic stimulation via the vagus nerve causes bronchoconstriction, narrows airways, increases RAAS.
And sympathetic.
Sympathetic stimulation, and especially circulating epinephrine from your adrenal glands, causes bronchodilation, widens airways, decreases RAAS. That's why epinephrine is used in severe asthma attacks.
What about chemicals, like histamine during allergies?
Potent bronchoconstrictor, histamine, leukotrienes.
Hmm.
These inflammatory mediators significantly increase RAAS.
But maybe the most powerful factor is just how inflated the lungs are, lung volume itself.
Absolutely, this is critical. At very low lung volumes, airway resistance is extremely high.
Why?
Two main reasons. First, as the whole lung shrinks, the airways within it also get narrower, just physically smaller. Remember, radius to the fourth power.
Right.
Second, there's this effect called radial traction, or mechanical tethering. The surrounding lung tissue, the alveolar walls, are attached to the outside of the airways. As the alveoli inflate.
They pull the airways open wider.
Exactly. They exert an outward pull like tether lines holding the airways open. The more inflated the lung, the stronger this tethering effect, the lower the resistance.
So that's why people with obstructive diseases like COPD or asthma often breathe at higher lung volumes.
It's a compensatory mechanism. By keeping their lungs more inflated, they maximize that radial traction to help keep their already narrowed airways as open as possible. It minimizes their resistance, even though it might feel uncomfortable.
Okay, this ties everything together nicely. The interplay between the pressures.
It really does. Remember, the brain controls the respiratory muscles, which directly set the intrapleural pressure, PIP.
And PIP then determines two things.
Right. It determines the transpulmonary pressure, PDP equals PA, PIP, which is the static part determining lung volume. And it also determines the alveolar pressure, PA, relative to the atmosphere, which is the dynamic part driving airflow.
So when you start to inhale, you make PIP more negative.
Which does two things almost simultaneously. It starts making PTP more positive, beginning to expand the lung, static component, and it makes PA slightly negative compared to the atmosphere, creating the pressure gradient for air to flow in, dynamic component.
It's like, first you need the pressure difference to cause flow, then you need the pressure difference to hold the new volume.
Beautifully put. As inspiration proceeds, more of the PIP change goes towards maintaining the larger volume, PDP, and less towards driving flow, PA, until flow stops at the end of inspiration.
This also explains dynamic compliance, doesn't it? Why compliance seems lower when you breathe faster.
Yes. Static compliance is measured with no airflow. Dynamic compliance is measured during breathing, as you breathe faster and faster.
There's less time for air to get into all the nooks and crannies, especially if some areas fill slower than others.
Exactly. Especially in diseased lungs, where you might have areas with high resistance or low compliance that fill or empty slowly. At high breathing rates, these slow units don't have time to fully participate, so the overall volume change for a given pressure change, dynamic compliance, appears lower.
Okay, one last crucial, maybe slightly counterintuitive point. Airway compression during exhalation.
Right. We said airways get pulled open during inspiration by radial traction and the negative pressures. But during expiration, especially a forced one,
Alveolar pressure becomes positive to push air out.
and intrapleural pressure also becomes less negative, maybe even positive, during a forced expiration. Now, think about the pressure outside the airways, PIP, versus the pressure inside them.
If the pressure outside becomes higher than inside?
The airway can get squeezed, compressed.
Yeah.
This is especially a problem in airways that don't have cartilage support, the smaller ones.
And it's worse in emphysema.
Much worse. Because in emphysema, that destruction of alveolar walls also destroys the radial traction, the mechanical tethering that normally holds areas open. So they're inherently floppier and much more susceptible to collapse during expiration when the pressure outside might exceed the pressure inside.
Which is why exhaling is so hard for them.
Extremely hard, leading to air trapping.
And they adapt, you mentioned, by breathing slowly, staying at high lung volumes,
Yeah.
and that pursed lip breathing.
Exactly. Puffing or pursed lip breathing. It seems odd, adding resistance at the mouth, but it's clever.
How does it help?
By creating high resistance at the lips, the biggest pressure drop happens there, outside the chest. This helps maintain a higher pressure inside the downstream airways within the chest.
Keeping the pressure inside higher than the collapsing pressure outside.
Precisely. It helps splint the airways open during expiration, reducing collapse and air trapping.
Which leads to this idea of effort independence in flow.
Yeah, this is fascinating. At lower lung volumes, especially during a forced expiration, you reach a point where trying harder doesn't make the air come out any faster.
Why not? If I push harder, shouldn't flow increase?
You'd think so.
Ah.
But as you push harder, increasing alveolar pressure, you also increase the tendency for those airways to compress.
So the increased driving pressure is offset by increased resistance from the collapse.
Exactly. The two effects cancel each other out, and the flow rate hits a maximum ceiling. Pushing even harder just causes more collapse, not more flow. It's effort independent.
So it literally doesn't pay to strain harder at those lower volumes.
Not in terms of flow rate, no.
Wow. Okay, we've covered a huge amount there. From the basic push and pull of the lungs and chest wall, the pressures involved.
To the muscles of breathing, the concepts of compliance and elastance, the critical role of surface tension and surfactant.
And then the dynamics, airway resistance, how it's affected by lung volume and disease, and finally, this airway compression and effort independence.
It's a really intricate system. You now have, hopefully, a much clearer picture of how every single breath is orchestrated, this interplay of pressures, muscles, and the physical properties of the lungs and airways.
And importantly, how things go wrong in common diseases like fibrosis, emphysema, asthma. Seeing the mechanism makes the disease make more sense.
Absolutely.
We really hope this deep dive gave you some aha moments and clarified these vital concepts. Remember, you're part of the Deep Dive family. You are absolutely capable of mastering this material. Keep digging, keep asking questions.
And maybe next time you just take a normal breath or even a sigh, you'll have a little more appreciation for the incredible mechanics making it happen, fine-tuning things constantly.